Dr. Tathagata Ghosh. I do practice general medicine back at Bardwell. So, what we are seeing nowadays regarding hypertension, it has emerged in our society as a burning crisis. And most of the cases we do interact in our clinics when they are overtly clinical. But beforehand, a long phase to go amongst those patients and amongst the common people population when they are actually undiagnosed to have hypertension. And I believe that is the most dangerous part of the disease process for an individual. During that period, while our body, our vascular cardiovascular system, our blood vessels, our peripheral neuroregulatory organs, release of different neurotransmitters, including everything. So many changes do go on during that time, and which actually stays indolent. We do not come to know actually what is happening there. The individual is completely unaware of the fact, and from that point of time, had we got the chance to get the lifestyle modified of that particular individual, we could have avoided so many crises regarding health of that person. So today it is a very relevant and I should say that is the most important topic amongst all the health related issues, particularly which affect a person day in and day out. So today we need to have a discussion, I feel, about the updates in hypertension. So what we need to be saying, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, and out of which 27% are attributed to CVD, means cerebral vascular diseases, which affects 45% people in the age group of 40 to 69. Raised blood pressure is among the most important risk factors for CVDs, we all know. Moreover, it remains poorly controlled due to low awareness about hypertension. What I was saying earlier, a person has developed hypertension, he is not knowing that. There are some symptoms, some findings, some signs, or some changes in his habit, activities, all these things are happening, but those are going on very silently. That is the most critical while intervening hypertension. So there's a lack of appropriate care through the primary care, lack of appropriate intervention at the very initial phase is the prime point of concern for us. And there is also poor follow-up, that is negligence from the end of the patient or the individual and the healthcare care provider too. In India, the prevalence has gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension had not got their treatment. Medication was used to control blood pressure in fewer than 1 in 5 of men and 1 in 4 of women with hypertension worldwide, as per WHO updates. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 of men and 1 in 4 of women with hypertension worldwide, as per WHO update. Now, International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter age range substantially had reduced CV adverse events in the STEP randomized trial, affirming the screen findings for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CVDs. Findings from now a second major trial supporting a lower target would unite the guidelines, which even among US professional societies ranges from thresholds of 130 to 150 millimeter of rate. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP, office blood pressure measurements, but also on out of office measurements such as ABPM or home blood pressure monitoring, 24-hour and nighttime BP measurements, were associated with greater risks of mortality and a composite of severe outcome. Thus, they may be considered as the most relevant measurements of estimating CVDs. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed combination of ACE1 or ARB plus CCB or diluent. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irpesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contained valsartan from every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. The valsartan recall accompanied by a significant increase in the rate of emergency department visit of by increased amount of 6%. The Hygiene study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints. The Hygiene chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CVD reduction. The largest study included a total of 19,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared with the awakening treatment. Thanking you all. Thank you so much.